Welcome to INP4. This is the neurological unit. In this video, just going to do a quick overview of your PowerPoint. I want to say right off the top that you really should watch the Variations 4 videos that are also on the YouTube channel that are housing all these INP videos. The Variations 4 videos on the neurological system go through a lot of the theory that are behind this unit in INP. So I don't plan on repeating much, if any, of that kind of pathophysiology and related explanations that are in V4. So I strongly recommend you look at that. In fact, a lot of the PowerPoint here is a review of that as well. I won't be touching much on the review parts. So the majority of this video, I'll just be kind of skimming through the PowerPoint, talking about a few things. Our focus will really be looking at the Glasgow Coma scale. There's an old version and there is an updated version. We will compare the two. There really isn't a whole lot of difference from our practitioner standpoint. There's a few changes in terminology, which we'll talk about later, but not a huge change in its application for us where we're working. We're actually going to use the old neurological record because two reasons. It's still out there. It's still being used in some facilities. And a lot of our VCC materials are using it already. And as long as we're aware of some of the terminology changes, there's really no harm in using that. But we'll compare it to the new one later on. So here we are in the PowerPoint again. Since some of this, or a lot of this, is review of variations, I'm not going to be talking about that again. That's the whole point of having both the courses. The variations is supposed to act as the theory side, and the INP is supposed to be more really the hands-on side of things. Important reminders here for you to look at, but again, it's a repeat of things covered in Variations 4. All this is repeat. So the purpose of the Glasgow Coma scale is early detection of neurological decline. That is its purpose. Very often it's used for people who've had head trauma, any kind of head trauma, a fall, for example, a body check in a sport. But actually on a general surgery ward where most of the patients haven't had falls or are not in there because of trauma-related injuries, we still use it. And some hospitals, the one that I take students to, will do a Glasgow Coma scale on every patient, regardless of background, at least once a shift. Why? To detect early, to have an early detection of neurological decline. So delirium is neurological decline because now someone's not oriented and maybe they're doing things that could possibly harm themselves or others during that delirious state. That is a neurological decline. So to say that the Glasgow Coma scale is only used for head injury patients is incorrect. It is always used for head injury patients, yes, but it's got wider applications. Although much of the discussion we have around it is often related to head injuries because it's quite common use, quite a common use. Okay, so the scale we're talking about, if you're not clear by now or you haven't opened up the document by now, here it is. This is the Glasgow Coma scale. This is a version of it. This is the old version, kind of VCC's makeup of it, but these are the categories that are on the old version. So this is a very basic neuro sheet. It's got the Glasgow Coma scale at the top. The Glasgow Coma scale has 3 sections: eye-opening, best verbal, and best motor. And that's it. That's the Glasgow Coma scale. And it's supposed to add up to 15. So most of you watching this video now, if not all of you, are going to score 15 on the Glasgow Coma scale right here and now. Okay, and then there's other stuff below that is neurological assessments. And believe me, if you actually go to a neuro ward, there's a ton more that you would do, but they're not Glasgow Coma Scale. This is not Glasgow Coma Scale. They are common neurological assessments, and they are very much, very much relevant to someone with a head injury or otherwise. For example, pupil size, as we know from variations, is a very relevant assessment to someone who's had head injury, but also a really relevant assessment for someone who's maybe had a drug overdose. So these are very relevant neurological assessments. The strength one, how strong limbs are, we do that all the time, like before we do a transfer assessment. So these are very relative, but they're not the Glasgow Coma Scale. I just want to be clear. When we talk Glasgow Coma Scale, we're talking about these three sections above that, taken together for a perfectly healthy person, add up to 15. So depending on the context of the patient, any change in a Glasgow Coma Scale typically demands, that the nurse or whoever's assessing immediately consult with the physician. Okay, regardless of the cause of the change, is typically a change in it is if it hasn't got some kind of explanation that is benign, or you don't know what the explanation is behind the change in the score, and the score drops by 1 or more, you need to consult a physician pretty quick. So let's go through the sections. You feel free to read through the PowerPoint on your own. I'm not going to read through that. I'm going to paraphrase that to make this video quick. So when we go through eye opening, one thing I want to say about eye opening right away is you don't start measuring eye opening until you've woken the patient up. So you go into a room, you go to wake the patient up. If you are unable to wake them, and you've tried, some painful stimulus, as they used to call it, or some pressure stimulus, as we now call it, and you still cannot wake them, and you're also talking really loudly, practically in their ear, practically yelling at them, and you're applying pressure, that's a code. Sorry, this is the picture here of applying pressure to the trapezius. That is typically what we mean by pressure, or in the old Glasgow Coma Scale, they call it pain. Anyways, I'm skipping ahead here, but I'm just making the point that if you get to the point where you're applying pressure to the trapezius, you're kind of yelling at the patient, and you can't get them to wake up, that, and their full code, that's a code right there. Okay, and that hopefully is not going to be the majority of the cases. The majority of the time, you're waking a patient up. Sure, they might be drowsy, they might be sleepy, but you should be able to wake them up and get them to open their eyes. That, once they open their eyes and they've woken up, that is when you start measuring eye opening, only after you've awoken the patient, only after they've woken up. Then, as you're talking to them, if they're able to keep their eyes open throughout the conversation, that is called spontaneous eye opening. If during the conversation their eyes are fluttering to sleep because maybe they're a bit tired from last night, or maybe they've got a little too much medication on board, and you have to go, Mr. Dhaliwal, and that causes them to open their eyes during the conversation, then that's to speech. Maybe that's not working and you have to do that trapezius squeeze, then that would be what used to be called to pain, or as it's now called in the new Glasgow Coma Scale, to pressure. You get no response at all, despite all these things, that might be a code situation. That's a serious, these are all relative declines in neurological status. If you can't measure it, you can't measure it. You just got to put a C. There's nothing we can do. If they got in a fight and they have, raccoon eyes because they got punched in the face, honestly, if you can't measure it, you can't measure it. Most patients you can, though. So moving on to, so then you score them here. They get anywhere from, a 1 to a 4, or, no score if you can't do it. All right, next section, best verbal response. Okay, maybe you can't do it because they've got a trach that's inflated. Remember all that stuff, or they can't talk to you, can't vocalize. Anyways, that's not going to be the common situation. I mean, it could be depending on where you work, but for most of you who are going to be going to gen surge and acute medicine, that won't be the situation for the most part. They'll get one of these scores. So if they're talking to you and they're oriented ×3, which you're always assessing, then they get the full score. If they're able to make full sentences, and the sentence in itself is, you know, fairly grammatically sound, but it's just confused. Like, for example, if they're able to say, yeah, I went, you know, I'm on a cruise ship right now and I'd like to order dinner, please. Well, that is confused conversation. They're not on a cruise ship, they're in a hospital. But the sentences are intact. They're able to formulate. This is all measuring the function of the brain, you know, what's it able to do right now. They're able to form sentences. That's fairly high level stuff. They're just confused. So they get a 4. 3 could be anything like word salad, where they can't even form a sentence. The sentence itself is completely incoherent. Like they might use rhyming words, bees, knees, trees, you know, as a response, for example. So they have the mentation to form a word, but they can't even form a sentence. So that's a step down in neurological functioning. Then, of course, you might just get moaning and groaning, where they can't even form a word. They don't even have the consciousness or the cognitive ability to form a word. So you get the idea. These are all step down in cognitive function. Then you give them a score. Okay. Then you go to the last section, best motor response. Best motor response is kind of like, hey, there's examples, you know, there is squeeze my hand. I don't think squeeze my hand is the greatest example, because they've noted that even patients in comas can have at times a reflex response to grabbing. So, I mean, I think generally it's okay to use it, but just be mindful that there's also a reflex in grasping too. So maybe you're asking something like, you know, can you raise your arm? I mean, that's not a reflex. Can you raise your arm? That could be an example. You know, can you grab that cup across the table there? Something like that. There's a little legend on the new Glasgow Coma scale that gives you some ideas of some movements to do with them. But the bottom line is, can they obey you when you ask them to do something physically? I mean, that's really what it's all about. So let's say they can't. What's the next thing? You're going to likely be applying pressure to the trapezius. Okay. And then we're going to talk about the next 4 things that could come up from that. So let's talk about localizing and withdrawing. So I'm actually going to take a minute here and go to the new Glasgow Coma scale, which is in your Moodle shell, because it actually has fairly good depictions of these things. So just before we go any further, because we said we'd touch on it, let's just do this now. What's the differences between the 2 Glasgow Coma scales? Remember, this in itself is a Glasgow Coma scale. The first section, the big difference is they've put to pressure here, and in the old one they say to pain, and that's all the only difference in that section. I'm not aware of any differences in section number 2. Oh yeah, they've used words in like word salad and sounds. So if they changed them, instead of saying, you know, incomprehensible sounds, they just say sounds. Instead of inappropriate, they've used just sounds. So they've changed a few words here. For the last one, the first 2 are the same: obeys, localizes. So the old one they call withdrawal, and then on the new one they call that normal flexion. Okay, so they just, you know, they've changed those words, but it's still the same as withdrawal. They call it normal flexion. Then they both have the abnormal flexion section on them, and they both have extension. Okay, so I actually really don't want you to get totally caught up in this. It doesn't matter which one you use from our practitioner point of view at the level we're at, because I know to people who made this difference, the practitioners out there, it is a big difference to them. And I don't want to diminish that. I just want to say that from our point of view, though, and what we're assessing on their typical gen surge, acute med, you're fine using either one. And honestly, we're not going to be testing you in INP on the difference between the old and the new. That would not be a good use of time. So like I said, we're going to continue kind of using the new one, sorry, the old one for now, because it's just simply what we have in our databases. And legitimately, it is the one that is used out in some places still. So it's really 6 1/2 dozen. And what that means is it doesn't really make a difference which one we use. So we'll go for the most convenient right now. And a legend, but the new one's good because it's got a nice little legend on it if I can just find my way back to the new one here. Here we go. So it explains some of those movements. So we had talked about localizing. You move down best, when you move down best, now I'm on the new one here, it doesn't matter, but when you move down, they can obey commands. Okay, so what would be some of the commands you might tell them to do? You might say, here it is. Any of these, can they grasp your fingers? I've already talked about how the reflex on that. Can they push and pull? There you go, feet. You could even do the same thing with hands on that one. They show drift here. Drift, again, is a good one. We don't always do this. Again, there's lots of neurological assessments we don't talk about in this course, but this is one that's on here as well, and it kind of showing you a picture of how to measure for drift. But getting back to the Glasgow Coma scale, if they have normal flex, so they're not obeying, so then you have to apply the trapezius squeeze. Localizing means they're able to cross an arm, the opposite arm, over the midline of the body and try and push your arm away. That's a fairly high cognitive function to be able to do that. If they drop down a level, they can't do that. Then they do what's called normal flexion, which means they just pull away from the pain stimulus. They flex that elbow and try to pull away. Abnormal flexion is where the feet are turned inwards and the arms come up kind of like a bunny, a sign of very, kind of late stage, it could be intracranial pressure. And then even worse than that, you apply a trapezius squeeze and they go into this position. That's called extension. So as is shown here, if we're looking at a clearer picture is right here. If we're looking at these two, this is your decorticate, a sign of late stage. That's your abnormal flexion. This is your decerebrate. That's your extension. That's even worse. These are both bad, but this one is worse. But they're both signs of late stage. It could be increases in ICP, for example. Don't worry about these ones here. A quick explanation here on how to do pupil checks. You can read through that yourself, and you've probably seen this done before. We can practice it in a lab, or you can find videos on this. It's pretty straightforward stuff. You're shining a light in the eye in a dimmed room, and you're looking for a constriction of the pupil is a healthy response, and then you're looking for that consensual response where you do it again and both pupils constrict. Like the left will constrict when you shine a light in the right, so that both constrict, and then you'll go to the left side, shine it in the left eye, wait for the left constriction, do it again, and hopefully the right constricts as well. That's called consensual. We don't always do accommodation tests, but it's there. But really, it's these ones for sure. If someone falls and hits their head, you're doing that pupil check right away because you want to measure, or it's one of the first things you do because you want to check, is this a really bad bleed or is there a slow bleed? Is the pupil fixed and dilated or sluggish and dilated, or is it fast to constrict? And if you're confused about what all that means, you need to go back and watch those variations videos. You got this case on John Rain, and I do encourage you to work through it yourself. The reality is, at the end of the day, there could be a lot of causes to his combative behavior. Anything from falling and hitting his head, to having alcohol withdrawal, to pain, to electrolyte imbalance, dehydration. There could be a lot of things. Really what should have been done is the Glasgow Coma scale should have been done more often, at least every hour. There should have been a CWA assessment done, maybe medications given for CWA, alcohol withdrawal, vital signs, pain management. There's a lot of assessments that should have been done much more often throughout the night. Again, including pain, GCS, and alcohol withdrawal assessment and intervention. Your actions now obviously are, and I encourage you to work through the case and come up with these yourself and how they would apply. What are your actions now? Well, you're gonna have to do those assessments, and who knows, he might need a CT again of the head, He might need Ativan, CWA interventions, pain meds, etc. Not going to talk about seizures. That should be repeat from previous levels. One thing I want to talk about is management of seizures in acute care. And we'll just kind of end with this slide here. Okay, so the seizure precautions, you get a patient and it says seizure precautions. Oh yeah, and by the way, for John Rain, you may have wanted to put him on seizure precautions. I mean, there's no harm in beginning seizure precautions yourself if you think a patient's at risk for seizing. You don't need an order to do it. It's just patting the side rails, looking at IV access, which I'll talk about in a minute, and making sure you have your usual safety equipment. So there's really no issue there with kind of taking some initiative on that as a nurse. That being said, there are some patients who come up where they've been flagged ahead of time as, you know, a risk for seizures or a history of active seizures, you know, not well controlled by medications, for example. And the doc will actually write seizure precautions in the orders. And so you'll get that. And then definitely, you know, that's something that brings your attention to it right away. And of course, you pad the side rails, you check your safety equipment as usual. But this whole thing might be a bit new. You know, typically if someone's having a seizure, and you can check protocols, but if at any point in time you think they're at risk for airway, compromised airway, you just call a code. You know, you're not going to wait around for them to stop breathing. You might need to call a code if you think the airway's at risk here. Outside of that, typically it's, you know, 4 or 5 minutes. If you can't get that seizure under control, you consider calling a code as well. Depends on the situation, but, you know, kind of 4 or 5 minute rule. But before that, very often what you like to do is if after a couple minutes, and the doctor should clarify the order, but typically after a couple of minutes, the seizure hasn't started to cease or to abate, you can have the registered nurse do a push of Ativan through the IV, and that will calm the nervous system and stop the seizure. So there's a couple of issues around that. First of all, if you see a patient that has seizure precautions, you want to know, does the physician want to have PRN Ativan or something similar to that for CNS depression on the PRN orders for seizures lasting greater than fill in the blank? Maybe the doc says 2 minutes, maybe they say 3 minutes, or maybe they say they don't want to do that at all. I, as a practitioner, have seen all of those situations. So I just want to be really clear about that in case you have people trying to tell you otherwise. I've seen all 3 situations. I've seen, or 2. I've seen, I've called doctors about patients who are on seizure precautions. First of all, I looked at the PRN orders and didn't see any IV Ativan. And so I called them and said, hey, you know, you flagged a patient with seizure precautions. Cool. Did you want to have PRN Ativan push for seizures lasting greater than 2 or 3 minutes? You know, you decide, fill in the blank. Did you want to do that? And I can be very honest with you and say I've had both situations. Don't assume, and don't let anyone else tell you what to assume. Some have said, no, that's okay. No need. I didn't write the orders. We don't need them. We're all good. No harm done. And I've had other physicians or residents at that time say, not a bad idea. I'll tell you what, let me order this, whatever milligrams of Ativan via IV, which would be push, if seizure greater than, and then they'll tell you 2 or 3 minutes, whatever it is they decide. And you write that on the orders, it goes in the PRN section. So that's the first thing you want to do, is check to see if that order is there. And if it's not, then you want to talk to the physician and see if they want to order it. Then if they order it, make sure it's on the MAR. Once you've identified that this order is on the MAR, then you need to take the following steps. You need to make sure that the patient's got IV access. There's no point in having that order if during the seizure they don't even have a saline lock in place. If they don't have a saline lock in place, forget about it. You're not giving it. It's impossible. Even if they have a saline lock in place, I would say you have to kind of maybe talk with the other nurse, the registered nurse, and figure it out between the two of you. Do you want to keep, if they're really at high risk for seizures and they've got a history of seizures that really need Ativan, you kind of have to figure this out. But if they did, then I would say you'd want to actually have an IV running on that peripheral line, even if it's running at just TKVO to keep vein open. Why is that? Because if you did need to give, again, pushing IV meds through is an RN responsibility. Okay, that's the RN scope. But you would have to collaborate with them, and you'd have to know, so that you can collaborate with them what we're talking about here. In any case, it's really hard to push an IV med through a seizing patient when all they've got is a saline lock. You got to stabilize that limb, and it's just not a good situation to be in. Much easier if they have an IV running. Maybe it's an ordered IV, like 100 cc's an hour, or maybe it's not ordered and you just started TKVO. You don't need an order to start TKVO, normal saline. And but you can get one if you want. And then you have an IV line there that the RN can use to push the med through the IV line over, a minute or two, whatever it is. And then after having said all that, you want your other RN, the RN, to be aware that they have this PRN order, because despite protocols, some RNs do like to have the pre-pulled Ativan during their shift. So they're not wasting time trying to pull it up while a patient's seizing. So that's neither here nor there. I don't want to get into all that kind of professional practice stuff, but some would like to have the heads up that this patient has a PRN push for a fairly intense potential situation, and they can decide how they want to deal with that in terms of getting ready to give that if the event should come up. That completes this video for this unit for now.